But this is something that I dealt with full time for 15 years, right? Arthritis, there's a lot of stats. So when we think of arthritis, arth is joint, itis is kind of inflammation, right? You have the itis. So when you think of arthritis broadly, we probably think of kind of those pictures that are up there. That's kind of, if you Google arthritis, some of the first things that'll come up. But when you talk about arthritis, actually, it's painful inflammation and stiffness of the joints. There's over 100 things that would qualify technically as arthritis. So I have to broaden our scope of mind a little bit. I'm not going to teach you about many of those, maybe just a few. So we know it's common. I don't need you to know these stats by any means. The point is that it's common, right? 1 in 4 people have arthritis in the US. It's more common in females because why wouldn't it be? It is more common in people who are kind of in fair health, which is why so much of the lifestyle, healthy diet, good exercise and activity, those people kind of have less versions and incidences of arthritis. But basically by 2040, more than a quarter of the US population is going to have arthritis as far as a formal diagnosis. So this is something you're definitely going to see and deal with. Hopefully I can coerce some of you into orthopedics and maybe even into joint replacement. I have a couple of the second years who they're definitely going that route. Kara might be going back. I've been talking to her for already about it. We got a plan for her. So the biggest thing, is arthritis is expensive to deal with. So that's another thing as we get into healthcare costs and healthcare ethics and some of those treatments that we'll have to consider. But today we'll stay more in the very didactic realm of arthritis, where we'll talk about all these: osteoarthritis, rheumatoid arthritis, psoriatic, gouty, reactive, septic, and gonococcal arthritis. So I'll have this picture kind of at the end. When we think of arthritis, I would recommend you figure out your own way to classify these. If you like charts and stuff, I have plenty of those for you throughout. So osteoarthritis is different than an inflammatory arthritis, which is different than a septic arthritis. All right, so we'll start kind of different classifications. And when you try to classify arthritis, the main 3 questions to ask are these 3 here. Is inflammation present? That's going to help you classify your arthritis. Inflammation is technically warmth, swelling, or morning stiffness of at least 30 minutes. Okay, so that's what I mean by inflammation. Any itis, yes, itis means inflammation. Arthritis, you're thinking, well, that always has inflammation. But in terms of the questions and classifying arthritis, this is what I mean by inflammation. So it gets a little hairy. You get what I'm saying? Okay, I know it's early, but good. So warm swelling and morning stiffness of at least 30 minutes. That means if we talk about an arthritis where all of that is less than 30 minutes, it's not classified as an inflammatory arthritis. Okay, so that's going to be a huge difference as we go to classification. Then we're going to ask how many joints are involved. So if it's one joint, we'll call that a monoarticular arthritis, something like gout. If it's polyarticular, it's going to have a lot of joints involved, like something like RA. And then we're going to say, are the joints symmetric or not? Is it both wrists, knees, and ankles? Or is it right wrist, left knee, and that's it? And then lastly, we'll use what joints are affected to help us figure out maybe what it could be. So your DIPs, remember where your DIPs are? You do? Good. DIPs, distals, the ones at the ends, that'll be something like OA and psoriatic arthritis. PIPs will be something different. And if there's extra articular manifestations, so kind of more systemic picture, fevers, rashes, nodules, neuropathies, that's going to help us kind of classify. So these are the 3 questions to start with when you're trying to figure out what arthritis you're dealing with. We'll start with osteoarthritis. Again, my main thing, right? The most common form of arthritis. This is the wear and tear. We correlate this with age. The older you are in years, the more likely you are to have osteoarthritis. Now, this is a degenerative arthritis. That's when we think the wear and tear, right? This kind of slowly occurs over time. It's not like you can fall, bump your knee today, and tomorrow you have arthritis. There's no acute osteoarthritis. All right. Now, this is considered a non-inflammatory arthritis. And I've underlined there, it's because the morning stiffness lasts for less than 30 minutes. So that's going to be a huge thing to know. I'd start that, it's underlined for you. but that's gonna help you classify this as a non-inflammatory arthritis. All right, there's not gonna be systemic symptoms from the arthritis. So people with osteoarthritis can get fevers and other illnesses, but it's not from the arthritis. All right, so these people are gonna tell you they have pain with activity that's relieved by rest. The further I walk, the more pain I have, but if I sit down, then it does improve. All right, when we look at x-rays for this, there's 3 very specific things we'll look at, and we'll get more into this in MSK and kind of x-rays, but it's gonna be joint space narrowing, osteophyte formation, and subchondral sclerosis. Does anybody know what joint space narrowing really translates to on an x-ray? That's that diagnostics. What is it, Briar?
Oh, just decreased space between the
Yes,
joints.
like literally that. 2 bones are here. When you look at the x-ray, joint space narrowing, the space between the bones, it looks like this. So there's just literally less space between the 2 bones. What you can't see on the x-ray is the articular cartilage, right? That soft cartilage on the end. So if there's less of that, there's less cushion because it's worn down slowly over time. Osteophyte formation, you know what that is?
Like bone spurs,
What is it?
like a bone spur.
Bone spurs. Yeah, osteophytes are bone spurs. And then subchondral sclerosis. Any thoughts on that? What, Michelle?
It's like more dense,
More
like increased density.
increased density. So that's something you see on the x-ray. Yeah, subchondral. So under the chondral surface or under the cartilage, sclerosis, hardening and thickening of the bone. So again, we'll get into this with MSK. I think you've had kind of intro to that. And then bony cyst formation. There's just going to be cysts within the bone. Those are normal, physiologic, fine, non-dangerous cysts. It's usually from joint fluid getting pressurized down into the bone and stuff there. So when we look at primary osteoarthritis, you're going to see this a lot in the DIPs, PIPs, CMC. Where's your CMC? Yes, Julian, right? The base of your thumb, carpal, metacarpal, carpal, wrist, metacarpal here. So base of your thumb. It's one of the most common places people get arthritis, right there. Hips, knees, that's my jam, replace them. MTP, where's your MTP? Where? Somebody said it. Your big toe, yep. And that's all primary. So that's kind of the wear and tear that happens over time, right? Secondary arthritis, we're not going to deep dive into that, but that's something if you have fractured a bone through a joint. Remember we talked about Salter-Harris and stuff like that. So if you have some of that basically as an adult where you fracture the bone through the joint, it can damage the joint, and then you're basically more prone to arthritis. So you have arthritis because you've already injured that initially. You might have metabolic disease. It's typically after a trauma. So there are differences to primary and secondary. They're not treated any differently, so we're not going to like super deep dive into that. But as far as osteoarthritis, again, it's a very slow onset. It's kind of that wear and tear. Highlights, joint stiffness will be less than 30 minutes. Over time, because of the bone spurs and because of the progression, the narrowing of space between the bones don't move as well. So range of motion becomes limited. And that's kind of what you see in those pictures on that first slide, right? People are kind of crunched or they're stuck or they're shuffling and they don't have quite the mobility. And that's not because they don't want to and they're not stretching well enough. It's because the joints don't move as well. So that's how they get limited range of motion. Again, worse with activity, relieved by rest. And then effusion and inflammation. I put her mild. It's a non-inflammatory arthritis, but people will say, oh, my thumb's all inflamed, right? Can it look red? Can it feel a little warm? Sure, but don't confuse that with being an inflammatory arthritis. Those are clinical signs of inflammation, but it's not classified as an inflammatory arthritis. Am I very clear on that? Okay. When we look at signs and symptoms, the hands usually get these very classic kind of bony enlargements. Did you look at this in diagnostics at all or hear about these? Herbert's nodes, Bouchard nodes. So I don't know how you guys want to remember. Herbertin and Bouchard nodes, PIPs and DIPs. Basically, however you want to remember it, lock that in. That's your little brain nugget. We talk about the knees. It's most common to get medial compartment wear. Again, we'll talk about this more in MSK, but you know which the medial is the inside compartment wear. So if you can imagine the inside of the knees have space that's gone and the outside of the knees have space that's still there, you know, it kind of bows the legs. They start to collapse. So that's how you get that varus deformity. That bow-legged deformity is most common in knee osteoarthritis. Now, if you get lab work, SED rate, CRP, you're looking for inflammatory markers. They should be normal, right? This is a non-inflammatory arthritis. So there's really no need to get labs for arthritis, especially osteoarthritis, which is the most common, the one you're going to be very highly clinically suspicious of. The best thing that we do is get x-rays. Those 3 hallmark findings are right there. So on the top left, you can see osteophytes, the bone spurs, kind of those red outlines show you the unevenness of the bone. Joint space narrowing, you can see again, there's just literally no space between the edges of those 2 bones. Subchondral sclerosis there, you can see that kind of dense, like Michelle said, that hyper pressurized white thickened area. There's some little cysts that are in there. So you can see on the left is an arthritic kind of hands and fingers, and on the right is what it normally looks like on an x-ray. So if this isn't a weight-bearing joint, we generally ask people to try to lose weight, reduce the pressure on those joints, send them to PT for some strength and mobility. As far as arthritis, can you cure it? I mean, in a way, I can replace the joint and cure it, but not really. You can certainly treat it. Symptoms may wax and wane and respond well, but you're not going to change the x-ray. So if you have severe bone-on-bone arthritis, I might send you to PT or give you some NSAIDs. You might say that you feel a lot better, but your x-ray is going to look the same. And over time, it's just going to look worse. So, you know, it is a degenerative process. The symptoms don't always correlate. But, you know, the prognosis is it's generally going to look worse. We'll see what we can do. All right. So it's all conservative treatment until you might get to the point where you end up doing a joint replacement. Joint replacement is resurfacing the edges of the bone with metal and putting some plastic in between to act as new cartilage. So when you think of conservative treatment, there's basically 1,000 things, like everything plus the kitchen sink. So lifestyle changes are typically first. NSAIDs are most effective, but that doesn't mean they're the best first-line treatment, right? Tylenol is typically where you're going to see acetaminophen is the best first-line treatment. This is a non-inflammatory arthritis, so you can use things like Tylenol, acetaminophen as, you know, a mild analgesic or pain reliever. But since the limited range of motion and the use of joints does irritate and kind of inflame them on a localized level, that's why anti-inflammatories help. So NSAIDs are the most effective treatment for PARM. Obviously, there's a lot of risks. So when you kind of think of the classic patient profile, it might not all be great candidates for going on NSAIDs if they have liver disease or they've had a stroke or cardiovascular disease or they're already on anticoagulants. So think about renal function. There's a lot to consider there. And that's why the orthopedists are always butting heads with the quote real medical providers, because we just give everybody NSAIDs anyway and let the other people figure it out. As far as topicals, there are topical NSAIDs. There's a lot more coming out. There's compounding pharmacies. So you'll see some other options, some pretty creative things to do. You know, you have to limit acetaminophen. It used to be 4 grams a day. I think now generally accepted it's 3 grams a day max for patients. Yep. Opioids, basically don't think about opioids for osteoarthritis. This is too much of a chronic disease to be treating with opioids. If they have a flare, something else, maybe for a day or two or something acute, but generally speaking, these are not good for osteoarthritic treatment. All right, you can do injections. There's different kinds of those. I have those on the next slide. PT, right? They're trying to maintain range of motion. It's where you're going to send someone to PT and they're going to feel like, oh, I've gained so much range of motion despite having the arthritis, because again, the x-ray is not going to change. So it's going to maintain range of motion, kind of maintain or maybe gain some strength. A lot of it is learning a home exercise program and patients will keep up with it. And then kind of learn how to function maybe in a different or alternative way to bend and pick something up off the floor, how to, do some things so they can adapt to living with the arthritis that they have. And then canes, crutches, walkers, all of those things, assistive devices can be used to offset the load on usually a lower extremity joint. Now, they have two hips with equally bad arthritis, that's when maybe you go to walker, but if it's unilateral, you go to a cane or something. And then bracing, depending what you're doing, bracing may or may not help. It can be a little controversial depending on which orthopedist you're talking to and what kind of arthritis they have. Some would argue that, and this is background, some would argue that, the brace does the work of the musculature. So by wearing a brace 24/7, the muscles actually get weaker because the brace is doing the work for them. So that's going to be hit or miss depending on the patient, what you're trying to help, and what kind of the real problem and severity is. As far as injections, is anybody familiar with why I have a picture of that chicken on the right? Who said it? Did you say it again? Yes. So on the left, we have classic corticosteroids. Those are steroid shots. We hear about these all the time, right? They reduce inflammation. Again, it's a non-inflammatory arthritis, but it reduces localized inflammation of bone rubbing on bone, right? Of course that hurts. It causes some issues. You can get one every maybe 3 to 4 months, probably 90 days is the published minimum. It does work quickly. We mix it with lidocaine or marcaine. So in a couple, minutes to hours, patients think you're a miracle worker, which is great. I never know how long they're going to last. It could last 2 days. It could last 2 weeks, 2 months, 2 years. I've heard it all. And that's pretty much indicated for all joints, soft tissue, and other things. The picture on the right, those are a different kind of injection. They're made from rooster combs. That's why the picture. It's called hyaluronic acid. If you watch a lot of commercials now, especially for like women's facial cream, it's all made with hyaluronic acid. Why? Well, I'm not a chemist, but it can absorb its, 100 times its molecular weight in water. So it's very hydrating is the point, right? So by using hyaluronic acid, we think maybe we can kind of hydrate, lubricate the joint. So even if it is bone on bone, maybe the bones slip against each other better, faster. So they don't know exactly how this works, but we call this kind of gel. We call this kind of viscous supplementation. And if you feel it, it is very slippery. I mean, it's people would say like, oh, I need the oil shot in my knee. And this is what they're talking about. So they can have it every 6 to 12 months. Some of that's dependent on insurance. And it works slowly. So probably about 6 weeks to get the full benefit. And then I tell patients it's like 50-50. I don't know. Maybe it helps, maybe it doesn't. We don't even know how it works, but it's pretty harmless. It's a natural substance. So by injecting it in the knee, there's only a couple cautions. If someone has a chicken or egg allergy, probably shouldn't use it in them, but now these are pretty much made synthetically in a lab. So we're not chasing roosters around anymore, but that's how it got its start. And this is only indicated for knee joints. So if someone says, oh my gosh, my thumb, can I have the lubricant in my thumb? I mean, some people do things off label, but there's no indication for it other than knee joints. All right. I mean, I used to set up injection clinics or injection half days where every 5 to 10 minutes, people would just come in and I would just inject them, steroids, this, all the other stuff. And it, it can be adjunctive therapy, plus or minus all of those other things for patients. Sherry, have a thought? The comb, which is, I think, this thing, right? Is it hair? Is it, or is it this thing? I think
It's this thing.
The top.
Is it this or is it this?
It's the
The
top.
top.
The top. They look the same to me. I think it's this.
The bottom's the gizzard, I think, right? Not to like flex my
I
chicken.
don't have any information on if the chicken's harmed.
I'm gonna have that. That bring up a lot of
I
trouble.
do know right now.
Yeah.
It's been a while.
You don't know my chicken's
I
harmed?
don't know. That's something we'll have to look up.
Oh my god.
I do not know.
Really same problem.
But, some of the things you'll notice with arthritis,
Separately your animals with
generally,
your
if we
parent.
rate it
Fur.
as mild, moderate, severe, their symptoms tend to correlate, but they don't always. We'll see some people with mild disease who have severe symptoms, and some people with severe x-rays who really aren't that bothered by it. And they just take some Tylenol and they're fine. So generally, there's a pattern. but it's not exact. So you could use any or all of these plus minus and give patients kind of a lot of education, a lot of control in their treatment plan and their options and what they want to do. To the point where some people say, I know if I walk for more than 10 minutes, my knee is going to be killing me. And my husband and I are going on a trip to Europe next week. Okay, well, I could give you some NSAIDs, take your Tylenol, you could use a brace for this week, you know, whatever. Or some people say, can you just give me the steroid shot now so that I know it'll kick in and help me by next week? Sure. So, you know, patients can be very involved in their treatment plan. Kind of what I see for osteoarthritis is our job is to responsibly give them the options, maybe a stepwise guide, kind of let them pick and choose what they think is going to work best. Opioids should not be part of the equation in their treatment plan. Thoughts or questions on OA? Okay. All right, moving on to rheumatoid arthritis. This is an inflammatory arthritis. So this is something that's chronic, it's systemic, it's inflammatory, and it's autoimmune. Once again, I think only one thing I'm going to talk about is more common in males. So I'll point that out specifically. Pretty much everything is more common in females. Classic onset, you know, what they call middle age, 40 to 50. And classically, you get the synovitis. So the synovium, the lining of the joints is where that inflammation happens. And it's multiple joints. This also is symmetric. Symmetric polyarthritis, many joints and symmetric, both wrists, both knees. Okay. Because it's systemic, there are extra articular manifestations. So beyond just the joint pain, swelling, and inflammation, the thing to remember, and we're going to break this down, but early and aggressive treatment is the standard of care. So most things like arthritis, think, oh, try some Tylenol, let's see, maybe do, you know, weight loss and some home stretches, and maybe PT, maybe a brace, maybe an injection, maybe this, you know, we kind of stepwise and ladder their plan. With rheumatoid arthritis, it doesn't feel exactly that. You know, when you're confirming this, early and aggressive treatment is where you start. Seems kind of backwards, right? But that's where we're going with this. So as far as classic signs and symptoms, you know, we'll start with the joints. Again, it's a symmetric swelling of multiple joints. So it's symmetric, it's polyarticular. And sometimes you'll see or hear a patient say that their joint feels boggy, or that's something you'll sometimes see written in like a clinical exam note, boggy knee. And it's because the synovium, the lining of the joint is so kind of swollen and inflamed. It's got a very unique feel to it. Different than just having a knee full of fluid and swelling. So it feels kind of swollen, but dense at the same time. These patients will have tenderness if you palpate and feel around the joint. They'll report pain to you as a symptom, and their stiffness is going to last for more than 30 minutes. So when they get up in the morning and they shuffle and walk around, it's going to take a while for them to kind of warm up, if you will. Where the arthritis patient with the bowed legs may say, yeah, when I first get up, I'm super stiff, but you know, I go in the bathroom and I'll, you know, brush my teeth, walk down, make my coffee. And as I kind of go back upstairs to get in the shower, you know, I've loosened up, you know, kind of takes care of itself. I feel a lot less stiff. These patients are going to be more than 30 minutes of kind of morning stiffness, if you will, or if they sit for a long time and get up, it's take a long time for them. See a lot of this in the PIPs, MCP again, wrist, knees, ankles, and the MTP. Very classic findings, and I have pictures for you on the next page as well, are going to be ulnar deviation, the swan neck deformity, boutonniere deformity, and a bowstring sign. So those are things you can just see a picture of someone with rheumatoid arthritis and usually kind of just be fairly clued in without even asking them a lot of questions. Now, in a patient with rheumatoid arthritis, about 20% have rheumatoid nodules, which you can see in that top left photo. These are rheumatoid nodules. They're basically subcutaneous. So subcutaneous under the skin, right? They're usually over a bony prominence, but they're right under the skin. They're kind of around some of the bursa or the tendon sheets. And we're going to get into labs at the end of the day today, but they correlate with what we call seropositive patients. Those are patients who have a serum positive rheumatoid factor. So I have this written down way later, but Not every rheumatoid patient has a positive rheumatoid factor. Just to confuse them. These patients might also have, eye symptoms. Dry mucous membranes like eyes and mouth. Sometimes it's because another co-contaminant autoimmune disease. Sometimes it's not. But you might hear some of these other things, right? The sclerotis, they can have scleral nodules as well. And then other things, they can have lung disease, pericarditis, vasculitis, which we'll do next week. And then if a rheumatoid arthritis patient has Felty syndrome, that means it's a patient who also has splenomegaly and neutropenia. There's a number of ways that we can classify kind of these autoimmune things. The big things to know about rheumatoid arthritis are right there at the top. Symmetric swelling of multiple joints, stiffness more than 30 minutes, common places you're going to see it, and those classic changes, which look like this. So ulnar deviation, you can see that in the picture at the bottom of the MCP joints. That swan neck deformity in that picture in the top middle. And then the boutonniere deformity. So they can mobilize, but usually at rest, that's the natural kind of resting position their hands will be in. And then for that bowstring deformity, it's really the prominence. Let's see if I can look around.
It hasn't been working.
Oh, so sad. Well, I guess I could point with my finger. Here, the prominence of these. So it's not the only sign. You guys see it over here, right? The prominence of these tendons here. So, some people have that naturally. It depends on their BMI, depends on their age, it depends on a lot of things. So you can't just base it off that, but usually you'll see a combination of these changes. Very easy to see typically in the hands. Now, because of this, it can limit activities of daily living. They'll have a decreased grip strength, so it's hard to open jars, open cans, open the toothpaste cap, big and little things. So sometimes these patients are more bothered by their limitations than they are truly the pain. A lot of patients are diagnosed younger and whenever able to cope with just the daily maintenance of living with some element of pain, discomfort, swelling. But it's really the function, the loss of function that most patients are bothered by. So if you go to get labs on these patients, one of the first things that there's a lot to consider, but one of the first things you might get is an anti-CCP. You're looking for this antibody that attacks your own healthy tissue. Now, that is the most specific blood test for rheumatoid arthritis, but it doesn't equal having a diagnosis of rheumatoid arthritis. Most RA patients will have a positive anti-CCP, but they won't. You have sensitivity, less specificity. This is the most specific for RA, but not diagnostic. You can look for rheumatoid factor. Half of the patients will have a positive rheumatoid factor early, usually by late stage, maybe 80% of them. But you can also have a positive rheumatoid factor with other autoimmune or infectious processes. So it's not specific to rheumatoid arthritis. You can also have rheumatoid arthritis and never have a positive rheumatoid factor. I have pictures on the labs later, so we'll kind of deep dive into those. But that's where we use the term seropositive, seronegative. We're talking about specifically a patient with rheumatoid arthritis. Do they have a rheumatoid factor that's positive or negative? Seropositive, seronegative. So it's not diagnostic, but that's kind of what those terms mean. Actually, you have thought? Yeah. Right, rheumatoid factor, you either have it or you don't. That doesn't correlate. And I don't remember off the top of my head, but I do have it later. So if I don't have it later, remind me and we'll take a look, but I think I have that later. Yes, I wrote rheumatoid factor. Levels don't correlate with disease activity. You kind of have it or you don't. But you can have it and not have a diagnosis of rheumatoid arthritis. So that's where some of these labs get hairy. We'll deep dive there. ANA, anti-nuclear antibodies, that's kind of one of the general screening labs and tests, kind of on a rheumatoid panel, if you will. That we think if you have this, you're more likely to develop or have an autoimmune disorder. Doesn't mean that you do, but you're more likely. Again, all these are relatively vague. I know it doesn't feel very helpful. Cetera and CRP, these are inflammatory markers. They're very sensitive. They're not specific. So kind of the joke behind Cetera and CRP is, if you sneeze 3 times in a day, they're going to go up because they're so sensitive, right? They're hypersensitive, but they're not specific. So, one way that we use that is to correlate with disease activity. If they're really, really, really high, we know that you're probably in a flare. If they're pretty low, they're probably having more kind of either remission or better days and they're well maintained on whatever current treatment. That's Cetera and CRP. They go up with infection, they go up with flares. So that is one that we can watch for trends. Now, when we get an H&H, that can easily show anemia of chronic disease. So some of these autoimmune things are very commonly associated with anemia of chronic disease. I know you've just had hematology. White blood cells should be typically normal. Sometimes they're changed. That neutropenia, the Felty syndrome is maybe one exception. And then an arthrocentesis, that's pulling joint fluid out of a joint. You can send that to the lab and have them look for things there. They can confirm kind of an inflammatory arthritis. So if I take joint fluid from someone with osteoarthritis with a lot of swelling in their knee, that's going to have different lab results than if I take joint fluid from someone with rheumatoid arthritis and send it for the same test. One will come back inflammatory, one will come back non-inflammatory. I have that in the lab section. We can go into numbers there. All right, the one reason where sometimes we use that in rheumatoid arthritis is someone comes in with a big, red, swollen, hot, painful knee. Some of the differentials, some of the caution should be, is there a bacterial infection is there? Or is this just a normal kind of rheumatoid flare happening here? And you don't want to miss the really dangerous full of bacteria knee. So that's sometimes when we pull fluid out and we make sure that there is no bacteria in there. It's, quote, just the rheumatoid arthritis flaring up. So I don't go around pulling fluid out of everybody's knees just to diagnose them with rheumatoid arthritis. That in itself is not diagnostic. There's many pieces to the autoimmune puzzle you have to put together in order to get really a diagnosis. So no one of these things can you run and then diagnose a patient. Make sense? Okay. So as far as making a formal diagnosis, like what's stuck in my mind, and every time I teach this, I have to relearn this, because in my mind, I always remember the American College of Rheumatology, which is ACR, and even in Europe, they kind of use this chart. So they use this chart, and in my mind, I always think, yeah, that's how you diagnose rheumatoid arthritis. It's not. It's a very good guide to increase your clinical suspicion, put together the pieces of the puzzle. The gold standard for diagnosing rheumatoid arthritis is looking at X-ray findings. And that surprises me every year. Now, in clinical practice, you're going to see everybody using the chart, which is why I think it's so ingrained in my head. You're putting together the pieces of this puzzle. So you're looking how many joints, are they polyarticular? Are they symmetric? What's the serology? Did you get a rheumatoid factor? What other things did you get? Did you get Cetera and CRP? How long has this been going on? So you kind of add together these scores. And that's why it says greater than 6 out of 10, definite RA. Yeah, that's not the gold standard of treatment, or gold standard of diagnosis, but it's clinically what's used quite a bit. But when we do look at X-ray findings, the downside is X-ray findings can lag. Someone can have all these crazy symptoms, you're running the labs, you're starting the workup, you basically want to use that chart to make the diagnosis because early and aggressive treatment is the standard of care. You can't say, well, I'm really suspicious for this, but we need to wait at least 6 to 12 months to get some x-rays just to confirm, right? Because at that point, the damage is already happening. So the goal is to identify this kind of using the chart, using the clinical pictures, putting together the pictures of the lab puzzle, diagnose early, treat early and aggressively, and avoid some of these complications that you'll see on radiographs. So hand radiographs are kind of the mainstay of if you're going to look for things where you're going to see the first changes. You'll see these bony erosions, joint space narrowing in a uniform way. That is technically different. Osteoarthritis doesn't typically have uniform joint space narrowing. Osteoarthritis has joint space narrowing that is only where the pressure is. So in a hip, you have a ball and socket, right, as we're standing. And so as you stand in weight bear, all the pressure goes through this part of the hip. So in osteoarthritis, the joint space that narrows is going to be here. That's where all the pressure is, walking, standing, jumping, running. In a rheumatoid arthritis patient, the whole thing would go. So even what's kind of medial, inferior, that's what it would look like, as opposed to just the chronic degenerative, chronic stress response. So that's what I mean by uniform joint space narrowing. You'll find these juxta-articular osteoporosis areas. So it's where, juxta-articular, right around the joint, the bone kind of thins. You get osteoporosis. The bone looks thinner, and you can see that. They're labeled in a lot of those. And then the erosions, which you can see. Those are some of the easiest things to see there. In a patient with more advanced disease, like in the bottom left, you'll see those classic changes. Ulnar deviation, right? You can't see a bowstring deformity. That's really a soft tissue thing, but you can see a swan neck or boutonniere deformity just on those x-rays. You can see the same thing that happens down in the knee. So for treatment, early and aggressive treatment is the standard of care. That's why we use that chart, try to get a diagnosis early and address it. The goals are to reduce inflammation and pain. That has good logical sense. We want to preserve function. We talked about how distressing that can be. And really, we want to prevent deformity. So the sooner we get a handle on this kind of chronic systemic inflammation, maybe we can prevent those severe deformities from happening. Again, mostly in the hands, some of the feet. So the gold standard are these DMARDs, right? You guys probably learned or are learning in PathoPharm. Learning soon. Today. Yes.
Said it yesterday.
Okay, so you heard the word.
It said the word.
Okay, well, I'm not going to deep dive into these. That's the good news. But DMARDs, they're disease modifying anti-rheumatic drugs. Sounds like a perfect thing to give someone with, rheumatoid disease. So those are the gold standard. DMARDs are kind of the class, right? There's these other things, synthetic versions of these, biologic versions of these, or combinations. All right, you'll hear about steroids. That's prednisone, right? Straight up steroids. We will give steroids to rheumatoid patients, but typically not as chronic therapy. That's normally, again, bridge therapy. So early aggressive treatment. This is an autoimmune problem. The body is attacking itself. We don't know why. Okay, so as soon as we look at that chart, we're pretty sure that's what's going on. We'll hit them with some high-dose steroids, early aggressive treatment, and bridge them until we can get them on a DMARD, right? Then we kind of come off the prednisone. Both of those things are inhibiting their own immune system from attacking itself. It's also inhibiting the immune system from attacking any bad stuff that's happening from the outside coming in. So that's why all these patients are at higher risk for, illness. So corticosteroids, after they're kind of maintained on their DMARD therapy, can be adjunctive therapy for flares. Very rarely, it's more and more rare now that they'll let someone be on kind of a chronic 5 milligrams of prednisone every day for life. It's a risk versus benefit thing. So the other steroids that we will typically use are, again, intra-articular cortisone injections into an inflamed or irritated joint.
The 10 milligrams a day is the dose that they give
Sometimes. Oh, you mean to start or for maintenance? To what?
to start.
No, to start, they're probably gonna go on like 50, 60. It's gonna be a high dose, 80. You know, again, that early aggressive treatment's gonna be way up there. Then they'll get the DMARD on board and kind of titrate that corticosteroid down. And if they can get them off it, you know, a maintenance dose is gonna be 5, and hopefully nothing. The goal is to get them off that prednisone on a daily basis. And then NSAIDs can be used for symptomatic relief. But again, we're trying to prevent that deformity, the x-ray changes. NSAIDs aren't going to have an effect on that, but patients might feel better. Here's some other thoughts on DMARDs. The most common one that you'll see, kind of, some of this is changing, but I think generally speaking, methotrexate is still the initial DMARD of choice. Clinically, you might see other rheumatologists reach for something else, but kind of as a whole, as a standard, you know, it's still published as methotrexate is the initial drug of choice. It does take 2 to 6 weeks for onset. So that's when we have that prednisone on board, early aggressive treatment. You know, methotrexate's once a week, and then you have to give them a daily folate supplement as well. The biggest concern there is hepatotoxicity. So again, you want to make sure that as your patients are on methotrexate, you're going to be pulling labs, looking at their LFTs. You don't want them on 3-4 grams of Tylenol a day, right? That's when you go maybe do a topical NSAID because you don't want other stuff going through the system. So hepatotoxicity is the main concern with methotrexate, but it's usually the first one that we try. Then we go into biologics, the TNFs. There's a lot of other stuff there. I'm not going to deep dive into those. And then you can do a combination. The thing is, you don't want to combine 2 true biologics. So you can combine methotrexate synthetic with a biologic as adjunctive therapy if needed. You don't want to take 2 things out of the biologic group and put those together. All right, but methotrexate, early aggressive treatment, start with steroids, bridge over to methotrexate, get off the steroids as quickly as possible then, if at all possible. Hepatotoxicity is a big concern. Those are the things that are going to prevent true disease progression on the x-rays and with the deformity. So NSAIDs can help, but they don't have any really effects there. All right, so as far as prognosis, this is probably going to be an early referral to rheumatology. This isn't something that most people feel comfortable handling on an outpatient basis in family medicine or internal medicine, just because some of these drugs have a lot to be considered. And RA does have an increased mortality with cardiovascular disease because the chronic systemic inflammation, and that includes the vascular system. So I've just spent all this time about joints and this and that, but in that chronic systemic inflammation can affect all the tissues, including the vasculature system. When I look and compare these things, osteoarthritis and rheumatoid arthritis, there are some very key differences, right? One is more considered cartilage loss, the wear and tear in response to stress. The other one's autoimmune. It's a synovitis, a chronic inflamed synovium, the lining of the joint, right? OA is less than 30 minutes of stiffness. RA is greater than 30 minutes. You know, osteoarthritis is asymmetrical. RA is symmetrical, and a polyarthritis. So a couple key things to keep in mind. I'll go through psoriatic arthritis, and then we'll take a break. So in terms of psoriatic arthritis, it's very commonly associated with psoriasis. That makes good sense. In most patients, they'll have a history of diagnosed psoriasis before the onset of the arthritis that can come along with it, but not always. Some patients can be diagnosed with psoriatic arthritis, and I'll tell you they've never had psoriasis. So those are the few. We're not going to focus on them. We're going to focus on the classics, right? History of psoriasis, and then they get this psoriatic arthritis. There's 5 subtypes of this. I'm not worried about you knowing the details of the subtypes. You can recognize them there, but the asymmetric arthritis is the most common. That's the one I want you to know. So when you think of psoriatic arthritis, think about it as an asymmetric arthritis. There are subtypes of symmetric polyarthritis. So I want you to think asymmetric. That's the most common, kind of make that association in your brain. Is it possible to have symmetric polyarthritis? Yes, that's some of the other subtypes. That is very commonly confused with or on a differential for rheumatoid arthritis for good reason. But another consideration for psoriatic arthritis is a lot of patients will have SI joint involvement. We'll get into other SI joint issues later. We'll get into labs again later, but these patients have a common positive HLA-B27. So not always, but usually when you're running all of these labs, see positive HLA-B27, this is something you should consider. Not diagnostic. When we look at the classic signs and symptoms, they're going to be stiff and painful joints, red swollen. They may or may not have current psoriasis as well. Most patients will at least have a history of psoriasis that you can get from them. All right, they'll have these dactylitis, which is kind of the inflammation in the fingers or toes. You know, that sausage finger is kind of what it's called. Sausage fingers, you see kind of on the top picture there, that's dactylitis. You look at their nails, you know, we ask in foundations, right? Hair, nail changes and all of that. Usually they were thinking endocrine. Well, we can also think derm, and this derm can go over into, you know, rheumatology. So they'll have nail pitting, the dents in their nails. You can see in that bottom two pictures, or onycholysis, where the nail's separating from the nail bed. These are very classic findings to see. You know, psoriasis usually the extensor surfaces, those white plaques. I had a patient with severe psoriatic arthritis. The hardest thing for him was he came in for a lot of injections for years. Totally, same story. And the hardest thing was trying to find kind of an entrance where I could safely give him an injection because his plaques were so severe. Some of his skin changes were so severe. And he'd had psoriasis since he was in his early 20s, pretty severely. He'd done like the black tar stuff. I mean, everything that's been, you know, from the beginning of time, a treatment for psoriasis, he had done. So he's, you know, kind of been in clinical trials, all of these things, but he had some of the worst psoriasis and psoriatic arthritis I've really ever seen. So if you get labs in these patients, they'll have a high seb rate, probably CRP most of the time, especially with active psoriasis, that skin turnover, you know, that's going to cause some chronic inflammation. These patients will be seronegative. So if you pull a rheumatoid factor, it will be negative. Their anti-CCP will be negative. Plus or minus, but probably a positive HLA-B27. That's more likely to be positive. And then their uric acid may be elevated. Any idea why? I wrote the answer down in the notes. I don't know if I gave you the notes. This was in the book. I thought it was interesting. It's definitely not like a migraine thing. I don't really care why. It's just good to know that maybe it will be. If you care to know why, write it down. In psoriasis, hyperuricemia may occur by increased epidermal cell turnover. Okay, that makes sense, right? That accelerates purine metabolism. I don't need you to know this from my class. And that has uric acid as the product of its catabolism. So anyway, it's like way down the line for migraine. As far as imaging, you'll find very specific findings. Osteolysis, the thinning, right? The lysing, the breaking down, the thinning of the bone. You see that pencil in cup deformity in the bottom right? You can see an example of that. So, you know, the proximal, so the distal end of the metatarsal kind of ends up in this little pencil tip. Anybody else go to school and put the pencil in? And, yeah. So you should make a really sharp pencil right before you take your Scantron #2 pencil test. You need that, right? You sharpen it all the way up.
Wood pencil.
And if you look at, just beyond that, you can see kind of the cup, the wide, almost umbrella that you put the tip of the pencil in. So on the bottom right, pencil and cup deformity, that's what it looks like. All right, you can also see kind of this fluffy bone, which sounds very cute. If you look at the picture at the top, you can see, especially in the middle, how it just kind of looks puffy and like clouds. There's some puffy periosteal bone. And then again, if you do, you'll see spondylitis and asymmetric sacroiliitis. That's going to be a key. Asymmetric sacroiliitis. We're talking about stuff later that's more symmetric sacroiliitis. So it's really knowing some of these very fine-tuned things that's going to help you differentiate what's what when it comes to rheumatoid diseases. So spondylitis, inflammation in and around the spine and bones, and asymmetric sacroiliitis. There we go. Here's your answer. Active skin turnover from psoriasis. That's why you have increased uric acid. Now, the problem with treatment is it's complicated because there's those subtypes and because they within themselves can be so different, the treatment is complicated too. I don't need you to know these charts. Not at all. All right. The only thing to notice is there are a lot of NSAIDs at the top of those lists. So generally biologics are the first line therapy, right? Rheumatoid, it's DMARDs. This is going to be biologics. And the other take home is the corticosteroids are less effective for flares than other inflammatory arthropathies. So for RA, super effective. Some of the other things, super effective. For psoriatic arthritis, oral corticosteroids, not going to be as effective. It's helping flares of the disease. Okay. All right. What do I have? 8:53. Why don't you guys take 10 minutes? 9:03. We'll come back and get into gout and pseudo gout. The first slide of Ken's 9-year-old with some weird germ thing, and I don't know what's going on. Any ideas? Yeah, I was gonna ask you guys because
Christine, I
My resident derm.
she'll know.
Well, I'll ask for consult because I still don't know what to say.
Yeah, she got a 30
I
minutes
told her to
okay.
take her to put her on Cathlex, which I think is the best thing, but now I'm wondering if she needs Bactrim. Anyway. It's not getting better. The red line's getting bigger. But we'll focus. We'll focus down to gout and pseudo gout. So
Why is he sharing Christine?
sound similar, clinically look similar, treated similarly. Yeah. But there's a couple key differences that I do need you to know, okay? So gout versus pseudo gout. This will kind of be your thing. We're gonna, go back to these pictures if you want. They're a little bit of humor, but as we start with gout, this is a metabolic disease with abnormal amounts of uric acid. Why does that happen? It depends. Some people are overproducers. More people are under excretors. All right, some people are both. And I don't know what percent because we're already at 100%, but that's what the book said. All right, this is most common in men. One of the two things today we'll say that's most common in men. There's probably a genetic component to this. And there are some common risk factors and associations. So alcohol, not like chronic alcohol use or abuse. This can just be a one-off, just alcohol. I had 2 beers last night. Boom, that might be enough. So it doesn't have to be history of chronic alcohol use. When you're looking at a social history, doesn't have to be that. Doesn't have to be any red flags with alcohol, okay? But alcohol is associated as you elicit a history. Purine foods, the common ones are red meats, organ meats like liver, anchovies, blue cheese, right? It's really good blue cheese dressing on a steak salad or something, and then sweetened drinks. This also can happen in patients who've had, trauma, recent surgery, where generally their body is just under stress. And common medications associated with this are thiazides and loop diuretics. So what happens? Chronic gout. Okay, we're talking about 2 things, but in chronic gout, this is if someone has long-term and untreated hyperuricemia. Doesn't matter if they're overproducers or under excretors. But if this is chronic hyperuricemia, they'll get these gouty tophi, which are what you see there. They're kind of deposits of crystals in a way underneath the skin. They're painless, So they look like they'd be painful. They're not. They're painless. They're hard. They feel like little rocks. That's uric acid crystals that are deposited right underneath the skin. If you look at the picture on the bottom left, you have to be careful because that can mimic rheumatoid nodules, right? Which are subcutaneous. You know, rheumatoid nodules are normally, again, kind of around joints, tendons, bursa. Gouty tophi can happen kind of anywhere. They are common on the ear, but again, more of the finger. So that, you know, you got to think about it and do a good exam in history. Another common place you see in the bottom picture is kind of in and around the elbow, kind of leaning on the elbow. And when we're looking at labs, imaging, but these are the things you want to know. When you're looking at acute gout, you're going to do an arthrocentesis, again, pulling fluid out, making sure you're not missing any bacterial infection, but pulling fluid out to look for uric acid crystals in the joint fluid. Usually the joint fluid's a little cloudy. You can kind of get an idea of what's going on. But if you take that fluid and put it under a microscope, you will see negatively birefringent crystals, which is what you see there. They're needle-shaped, those gold needle-shaped ones, right? That's negatively birefringent. If you want to know more about that, you can Google it. I'm not going to ask you. If you look at the synovial fluid, again, we'll get to deep dive in labs later, but it's going to come back as inflammatory. You'll typically see an increased serum white blood cell count. And their serum uric acid may be elevated, may not be. So typically, the questions are around getting an arthrocentesis and you see negatively birefringent crystals. That is associated with gout. Now, chronic changes, you'll see these rat bites on the x-ray. You can see in the picture on the bottom left, kind of these punched out erosions. I say an overhanging rim of cortical bone. We call those the rat bites. And I don't know that I've ever seen anybody do an ultrasound, but sometimes people say they can see the crystals with an ultrasound. Doesn't sound realistic to me. That's chronic gout. When we look at acute gout, this happens very, very quickly. I'm gonna be out, party, have a couple drinks, whatever, nice steak dinner, red wine, wake up the next morning, boom, they have severe pain. Usually it's in the big toe, called a podagra, the first MTP joint. It's monoarticular, it's only one joint. Usually it's the lower extremities, it can be the ankle, it can be the knee, it's very classically the big toe. It'll be very severely tender, very painful. They'll tell you, I can't even lay the bed sheet on it. It's so excruciating. These are the patients that will tell you they have 10 out of 10 pain. They can't walk. They're very stressed by this. Usually comes on overnight. It's an atraumatic injury. You can see the surrounding skin looks inflamed. They'll be warm, swollen, kind of that dusty red skin. And they might even have a systemic fever. All right, I think that goes back to the hyperuricemia, whether they have that or not. But most commonly, this is what you're going to hear with gout. Atraumatic, overnight, very sudden onset, 10 out of 10, pain, usually lower extremities, big toe. All right, so we treat it typically with NSAIDs. They're the first line treatment of choice. Usually it's indomethacin, and you can high dose them, 50 milligrams, 3 times a day until the symptoms get better or resolve. You can also use colchicine, kind of a loading dose that you give them, and then a maintenance dose. You guys learned about colchicine yet? There's a pretty significant side effect profile. We'll call it bowel distress. So it's kind of a joke that you would give someone colchicine, you give them a loading dose and give them a maintenance dose and be like, just stay on this till you poop your pants, then you've had enough. Like, that's literally the joke about dosing it. So severe GI, cautions should come along with giving someone colchicine. And then we can also give someone corticosteroids, either PO, so a tapering dose, high dose prednisone tapering down. You can give them an injection, an IV. You give them a localized injection into that area, but I will tell you right now, anyone who has gout is not going to even, they're not gonna let the bed sheet touch it. They're not gonna let you come at them with a needle and put more fluid in that space. But the good news is the steroids do give pretty dramatic improvement. So very quickly, they'll feel like they're getting better. All right, the one thing I did kind of write down there as far as steroids and treatments, you want to make sure this is gout and not a septic arthritis, which we haven't talked about yet, but we will. So you want to make sure that joint's not full of bacteria and pus, because adding steroids to that, not a good idea. All right, as far as managing it, you know, some people get this once and never again. Some people have this more chronically. It's usually coming in flares. The goal, you know, if someone's got a couple flares of this, you want to reduce why, you know, the uric acid levels are involved. Counsel them on a diet, right? Avoid the purine foods. Be very careful about alcohol. Stay as hydrated as you can. You know, if medical history and medications, patients are on thiazide and loop diuretics, you might want to switch them off them if they're getting chronic gout, more than 2 episodes of gout. Some people go on a prophylaxis of either colchicine or usually allopurinol. So that would be kind of a chronic maintenance medication to decrease serum uric acid. And then the goal, ultimate goal is to get a uric acid level below 6 in these chronic patients. All right, so the guidelines there say patients with gouty tophi, joint damage, those rat bites, or frequent flares, which they consider 2 or more a year, those people might be on prophylaxis. All right, allopurinol, typically first line for prophylaxis, NSAIDs treatment of choice. I have a lot of patient education that goes into that. As far as some of the prognosis, you know, if you get these common recurrent attacks, you see what happens on the x-ray. That does cause joint damage and then a secondary, you know, more chronic arthritis, but it also gives kind of an acute arthritis as well. All right, as we move to pseudo-gout, a couple things that are different. Crystals are different. Crystals are calcium pyrophosphate crystals. They deposit in the fibrocartilage or the hyaline cartilage. So we call this chondrocalcinosis. So chondrocartilage, calcinosis. Crystals go and kind of calcify, right? And kind of give you that look of calcification within other cartilage. So in the knee, that's the meniscus. See those arrows pointing at kind of those thin white lines? That's pseudo-gout crystals that are chronically deposited in the meniscus there. So this can have acute flares as well, usually in older patients. Most commonly, this is in the knees and wrists. Remember, gout typically lower extremities, most common in the big toe. Both can happen in the knees, but if it's wrist, it's most likely pseudo-gout. The presentation is going to be very similar. Patients are basically going to give you, bless you, the same history. Okay. As far as diagnosing this, if you get fluid, you'll see positively birefringent crystals. It's the gold standard to diagnose it. I'll show you on the next page, but those crystals are blue, they're rhomboid shaped. That's all the way they react to the light. So gout versus pseudo-gout, you want to know what shape the needles are. You want to know what crystals go with which. So positively birefringent goes with pseudo-gout. P and P go together. Okay, that's how I always remembered it. I don't care how you remember it, but I would really love for you to remember it. I'm sure you would at the next exam too. Really love to remember that. So gout versus pseudo-gout. Now, clinically, if someone comes in and they have all this stuff in their knee, you have to do an arthrocentesis and see what it is. No, you treat gout and pseudo-gout the same. So it doesn't really matter if it becomes chronic. Maybe that's something, again, that you look into more. You do want to make sure it's not a septic arthritis, but it's very classic to see that. We talked about reactive arthritis. This is also called Reiter syndrome. This is arthritis that happens 1 to 4 weeks after a bacterial infection. And you can't recover the pathogen from the joint that it's currently affecting. So most commonly, this is after something like an STI. Most commonly chlamydia, maybe a urinary tract infection or an intestinal infection. So after you have that infection, and then it's kind of cleared or treated, then you get the secondary reactive arthritis or Reiter syndrome. The three classic symptoms you should know, this triad, is arthritis lasting greater than a month, uveitis or conjunctivitis, and urethritis. So I have on the next, I don't know, somewhere in here, kind of those three things. We'll also see, again, maybe some dactylitis. I gotta keep that in mind with some of the other things we've discussed. You might see a rash, might see some oral ulcers. It's a couple things, but it's usually a strange collection of symptoms to see together. That's why asking about some, recent illness, sometimes you can tease this out. You're usually going to diagnose this clinically. So it's going to be on the MSK route, it's going to be an oligoarthritis. So many areas, many joints with arthritis of the peripheral joints, usually again, lower extremity. I'll have evidence, kind of a pre-existing extra-articular infection. So something that wasn't a joint infection, but now is affecting the joints. And then lastly, can't find anything else that it would be. So it's almost a diagnosis of exclusion. It's a weird bunch of things to put together. So this can present like many other rheumatologic diseases. If you get a rheumatoid factor, it will be negative, seronegative. They may or may not have this HLA-B27. As far as treatment, you want to give antibiotics to treat the initial infection if it's not yet cleared or happens. You can give NSAIDs for supportive care and kind of cautiously give steroids as needed and if indicated. That's always kind of a risk-benefit ratio. But if you look at the prognosis, this is fairly distressing. This can last 6 to 12 months. Have an illness, a month later, you get this polyarthritis, you get these other weird symptoms, and that could last a year. That's fairly distressing. These people are going under, rheumatoid workup. And kind of those triad of symptoms, conjunctivitis, urethritis, arthritis, the way that this is classically taught is can't see, can't pee, can't climb a tree. So can't see, eye symptoms, conjunctivitis, can't pee, urethritis, can't climb a tree, arthritis. And that's what that kind of saying mnemonic is meaning, is those triad of symptoms. I have a post-reaction to another infection. STI is most commonly things like chlamydia. And now let's talk about septic arthritis. So septic arthritis is acute bacterial arthritis. It'll be inflammatory at a monoarticular arthritis, so one joint. It's more common in kind of the large and weight-bearing joints, so that's hips, knees, ankles, maybe the wrists. The strong association with IV drug use. And this typically is hematogenous spread, so you can find this somewhere else in the body because it's going throughout. Usually it's Staph aureus. Let me put this picture together. It could be something from a skin infection. It's usually something like a, hematogenous spread, but it could be a direct inoculation, do a joint injection and don't use good sterile technique. That I introduce something into a joint I'm injecting and cause a septic arthritis? Possible. But most commonly it's this hematogenous spread. All right, this will be pretty apparent. It's got an onset that sounds like gout, right? A very acute onset of pain, swelling, and warmth. And it worsens in hours. So patients with this, maybe they wake up with this. And by noon, It's totally changed. So what they thought was something mild at 8 a.m. is excruciating. They're in the emergency room in hours. All right, this is most common in the knee. Again, large weight bearing joints, maybe the wrist. These patients might have systemic fevers and chills. It depends how long this has been going on. Most of the time, it's just in one joint. But if you pull fluid out of their joint, it's going to look like that. It's going to look like straight up pus. Patients who are on immunosuppression, they're at high risk for this landing in several joints, which is really, really very dangerous. Those patients get septic very quickly. And in the wrong patient populations can be deadly. Something you don't want to miss. The gold standard for this is to get synovial fluid, take the fluid out of the joint. This is what you don't want to miss in all of those other things we talked about with those red, warm, inflamed joints. This is why sometimes we're taking fluid out of a joint to make sure we're not missing this. All right, the key is you need to get fluid out of the joint before you treat. Don't give someone antibiotics when they walk in the ER and then say, oh yeah, I'm not really that comfortable taking fluid out of your knee. So let me see if the ortho PA can come down and do it. But I'm going to give you these antibiotics because clearly something's infected and something's going on. Why does that order matter so much? It will affect the culture. So they give antibiotics at noon when the patient comes up. I'm in surgery until 4, 5, who knows? I come in, then I take fluid out. It looks like all straight up pus. Obviously, it's some type of septic arthritis. I send cultures to the lab. And the lab calls back in 2 days and say, nothing's growing on these cultures. So well, it's impossible. I had a tube full of pus I took out of this knee. So the antibiotics can start to affect already and mess with your cultures. The problem for that is now we have to treat someone. We don't know what we're treating. It's probably Staph aureus, but maybe it's not. You kind of close yourself there. So as far as best practices, you want the culture before giving treatment. All right, as far as what the labs will show, this is inflammatory. And you can see right there in your aspirate what's happening. You're going to have a lot of high neutrophil counts. You do want to send the gram stain. It's probably going to be staph. You may get blood cultures if you worry about your patient being septic. If this patient has a total joint replacement, they're at much, much higher risk for this happening. And kind of the lab values change in those patients. But in your ER rotation, if you see this in a patient with a joint replacement, kind of the standard numbers of what we will accept as inflammatory versus kind of a native joint, what we accept as inflammatory numbers are different. The problem is when you replace a joint, you put metal and plastic in that joint. And metal and plastic are very easy places for the bacteria to hide because metal and plastic don't have an immune system. They can't fight that infection. So that's one reason why, we kind of stratify the numbers a little bit differently about what is allowed. As far as imaging, we usually don't do imaging for this. It's pretty much a clinical diagnosis you confirm with aspirating. If this is a chronic thing, and it definitely can be, a lot of joint infections, again, metal and plastic, you can kind of get it to be a subacute infection. But sometimes in those patients, they'll come in with like a sinus tract and they'll say, oh, the front of my shin just got this little opening and then it looks kind of like there's some pus coming out. Right, that's probably from the joint and it's made this little river all the way down until it found a place out. So that's when we get to, true ortho and MSK. We're treating things so differently when there's metal and plastic as far as in the joint versus not. So there's algorithms for a lot of these things. Notice that they all start with that joint aspiration. And if you can't get it, then you use imaging to get the aspiration before you truly go to a treatment with antibiotics. So that's kind of the mainstay of this. All of this will kind of depend on what you're doing and what you find. But make sure you get the fluid first before you treat something like this. A lot of deals here, a lot of differentials, things you don't want to miss. This is just if you like the charts and the prettier pictures than my slides, the same information. But usually when you have that, you're on antibiotic therapy for about 4 to 6 weeks. And again, you want to get the gram stain, you want the culture, you want the sensitivity. So you'll usually start broad spectrum coverage, treat for staph because that's probably what it is. This is a picture. Maybe of me doing a revision, but the surgeon in the bottom picture, this is when we were in Cuba. And he has a joint replacement. And he started having some tooth pain. And then he figured out that he was probably getting like an abscess. So in the middle of Cuba, there wasn't really much that we could do. But we did start an IV and run a ton of antibiotics into him. Because if that had festered and gotten kind of truly into the bloodstream, it would have gone right to his hip replacement, settled, and caused a huge issue. So that's one way that sometimes we treat patients differently, knowing their full history. So if you miss something like that, then you'll end up where I am in surgery. You're going to have, a surgery to open up the joint, try to wash and clean everything out. If you have a joint replacement, we'll probably take the metal and plastic out because it can't stay there, and it turns into a whole thing. But mortality is, it's there. It's about 30% of patients who have polyarticular sepsis, but it is able to spread and go to multiple joints. I mean, truly, they're septic. Those patients get very sick very quickly. It's another reason why you really want to get the culture and figure out what you're dealing with, so you're not kind of chasing your tail trying to help. All right, this slide should look fairly familiar. Yeah, 1 or 2 of you seen this before? I didn't even bother to change the background. Hint, hint, you've heard this before. But yes, as we talk about gonococcal arthritis, we've hinted at this before. These kind of happen in the quote, healthy young individuals, right? Again, more common in women, large joints like the knees and ankles, and this is a common recurring theme. The knees seem to be involved in everything. And then any association with Fitzhugh-Curtis syndromes. Anybody remember what that is?
Scarring on the uterus or the liver.
Perihepatitis, yes, so around the liver capsule, yep. So gonococcal arthritis has this migratory polyarthralgia. So the joint pain will move around for a couple days before it settles. So it's not like, oh, my knee started hurting on Monday, now it's Thursday, it still hurts. So it's like, well, my knee was hurting, then my shoulder, and then kind of my wrist. So it moves around. These are kind of vague and moving symptoms. That classic triad, we call it arthritis, dermatitis. It's tenosynovitis, dermatitis, and then that migratory polyarthralgia. After it moves around for a couple of days, it will settle into typically one joint. And then you can get kind of what we just talked about, that septic joint, right? Gonococcal. And chlamydial infections are very common. Some people with that dermatitis, they get those small pustules over the palms and soles or other extremities. They might have a fever. Again, they can have urinary symptoms. Sometimes that, you think about the reactive arthritis. Remember that triad, CP, tree. We got the P thing in there. This might have urinary symptoms. So there is some crossover and consideration when you really look at these as far as formalities, making differentials and try to figure out what's happening. So can they have a little bit of reactive arthritis? That is a gonococcal arthritis, kind of. The important thing is you need to look basically for a potential source where you can culture. So you need to look in the throat and you need to do a GU exam. So if you do labs, you'll find pretty much an elevated serum white blood cell count because this has been moving around. They're more likely to get septic. You look at the synovial fluid, most of the time you'll be able to find a culture, grow something. And then you need to do some NAT testing, which is probably why you need to do those swabs, right? Throat and kind of GU swabs. far as treatment and prognosis, you're probably going to admit these patients first, start them on your dual therapy, progress them to outpatient. But the good news about this is someone comes in really sick, really in pain, all this stuff, you start them on the right, you get the fluid, you start them on the right antibiotics. Within 24 hours, they will look like a different person. For one, that's a good sign you're doing the right thing, right? They're getting better, but they get better quickly. So they will look night and day, a dramatic response to those antibiotics once you start them. All right, so going back to our chart, then some arthritis, right? Osteoarthritis, degeneration, the wear and tear, non-inflammatory, primary and secondary. We have the inflammatory things we talked about, rheumatoid, psoriatic, and then the crystal things, gout and pseudogout, and then septic arthritis as well. A couple things, differentials. Again, if you like charts, here's your charts, right? Monoarticular versus polyarticular, and then symmetric or not. And you can think of some other things, pulling in some infectious disease maybe that would be on your differentials. So quick review of some super important things. We classify arthritis. Ask those three things. Is inflammation present? How many joints are involved and which ones are they? Osteoarthritis on x-ray has those three things: joint space narrowing, bone spur, osteophyte formation, subchondral sclerosis with the cyst. OA stiffness resolves in less than 30 minutes. Now where those nodes are, joint aspiration showing a negatively birefringent crystal, the gold standard for acute gout. You can't look at someone and say, oh, it's gout or pseudogout. You got to get the crystals to confirm. Most of the time, we don't care because it's treated the same. But if you want a gold standard diagnosis, you have to get the fluid, you have to look at the type of crystals. Most commonly gouts in the big toe. Problem with tophi is uricemia. NSAIDs are first-line treatment. Allopurinol, chronic treatment. Okay. Positively birefringent with rhomboid needles or pseudogouts. RA is an inflammatory and autoimmune disease, classic symmetric and polyarthritis. No swan neck deformity, boutonnieres, ulnar deviation. The hallmark of RA on x-rays is different. Bony erosion, symmetric joint space narrowing, not juxta-articular osteoporosis. Standard of care, early and aggressive treatment. Usually, DMARDs, biologics, the steroids will help you bridge. Psoriatic arthritis, that's the dactylitis, the nail pitting, the pencil in cup x-ray finding. Biologics are given for psoriatic arthritis. They're not going to respond as well to steroids. The reactive arthritis with your classic triad, PC, climb a tree. Septic arthritis, usually Staph aureus, hematogenous spread. It gets dramatically worse within hours, but will respond quickly to the correct antibiotics. Pneumococcal arthritis treatment of choice, twofold, azithromycin, ceftriaxone. Okay. All right, let's go through some thoughts and labs. First of all, when you're getting fluid, never aspirate through cellulitis or psoriatic plaque. You also don't want to inject through those, but when you're getting, if the whole knee is red and swollen, it's tricky. I'd have to get creative with how you're going to get some fluid out of it, right? So normally I'd aspirate on the lateral side of the knee. If that's where a big, red area is, got to change, got to figure out another way to get fluid without going through an affected area. All right, do you want to use caution in patients who are on heavy anticoagulation therapy? If someone's INR is 4, and I need to aspirate their knee, I can probably get fluid out, but I might cause a whole bunch of bleeding within the knee and then they have this huge hematoma. Just be cautious, kind of know their history. When you look at fluid, look at it with your own eyeballs. Is it clear? Is it full of pus? Is it a gel? Is it, what's in there? Is it blood? And you can do a microscopic examination, again, crystals. Then you'll get a cell count. This is where I was talking about For certain things, the rules change, but generally speaking, when you get a cell count out of the fluid that you send, you want it to be less than 2,000. Sorry, 200. If it's greater than 200, but less than 2,000, that's when we say it's non-inflammatory. It's somewhere in this much wider range, it's inflammatory. Your cell count's over 100,000, it's septic, it's purulent. You probably don't need a cell count at that point, because you can just look at it and already tell. All right, when you send a culture, send odd numbers, like 3. Need more than 1, why do you need more than 2? Tiebreaker. So this grew staph, this didn't. Is it a contaminant or what happened here? Yeah, so 3. Send 3 cultures. All right, the gram stain can be helpful. At least 50% of the time, not bad. All right. When we're aspirating or injecting, the risk of infection, that's something to consider. All right, this is a bunch of tables, some from published articles, some from your book. The whole point of this to say is I give you general guidelines on that first slide, go by those, but can you find other resources where you say, Professor G, you're wrong? Yeah, you can, they're right here. So there's some general accepted numbers, bless you. But you'll find variations within that depending on the data source that you're looking at for normal and acceptable white blood cell numbers versus not. Yeah.
Sorry, just for the cultures.
Yep.
So you're doing 3 separate, fully separate draws from the same.
Sorry, good question. No, one joint aspirate. So you have the big tube like I have there. You put it into 3 separate culture tubes.
Okay.
Yes, thank you. Oh my God, people will punch you.
That's why I
With
was like.
an 18 gauge needle in a joint that hurts at all, never mind 3 times. Thank you for clarifying. All right, here we go, rheumatoid factor. All right, so look first, the picture on the right? Seropositive, seronegative. That literally means when they analyze the blood, is rheumatoid factor in it or not? Okay. So it's an autoantibody that helps diagnose inflammatory diseases. You can have rheumatoid arthritis, but be seronegative. Great. Most of the time, they'll be seropositive, but not always. And rheumatoid factor does not fluctuate with disease activity. It's either there or it's not. Let's see, I wrote this down. Let's see. Anti-CCP. These peptides are kind of autoantibody that attacks your own healthy tissue. This is why we use steroids and DMARDs and biologics. We want to kind of turn that peptide off, right? But we're looking in the blood by labs to see if it's there or not. So high levels can help diagnose rheumatoid arthritis because that's autoimmune and this peptide is associated with autoimmune disease. Now, you can test negative for anti-CCP and still have RA. So okay, patient can be diagnosed with rheumatoid arthritis and be negative anti-CCP and negative rheumatoid factor. Great. The testing for, if you test positive for anti-CCP, it can predict more aggressive disease activity, but TBD. So actually, it doesn't say if it correlates. Doesn't sound like it. Thank you. So this will change as far as amount, but it's either there or not, and then this correlates. Okay. ANA, anti-nuclear antibody. This also can be kind of the broad screening test for autoimmune pathology. For example, we'll talk about this next. Most people with systemic lupus will have a positive ANA. But it can be positive in other autoimmune diseases as well, like rheumatoid arthritis. So ANA is better at helping with the diagnosis than it is for tracking disease activity. So to Aisha's question, Ceterate and CRP are generally how we track disease activity. We don't use things like ANA. As far as I know, I don't think we use anti-CCP, even if it's possible to kind of track how it's going, how responsive therapy is. All right, as far as ANA, this is kind of the take home of what I want you to know. If you do more research, you can deep dive into ANA. There's different ways that you can look at the autoantibodies and how they're made, if you will. And that can also help point you to other disease or specific autoimmune disease pathology. This is not quite the level I need you to go. I don't need you to know that homogeneous is associated with RA and lupus and speckled is with scleroderma. That's not the expectation for you. But if you have interest, you're curious, you've read about some of this, you have to look at the Hep2 cell line to correlate all of this, and it can be helpful. This is something, again, the rheumatologist, specialist, lab people can do kind of for you. I don't need you to know that level of detail. Okay. So here it's saying about titers and all of these things. Generally, it's non-specific. You can't see it in other conditions. All right, HLA-B27. This is the serum test. You're looking for a protein on the surface of white blood cells. It's human leukocyte antigen B27, HLA-B27. There's some genetic component with this. When patients test positive for this, we think they have a greater than average risk for developing an autoimmune disorder. So we talked about some that are associated with HLA-B27. We're going to get into ankylosing spondylitis. That's kind of the big one that's commonly associated with spondyloarthropathies. We talked about reactive arthritis, but autoimmune does not equal arthritis. All right, so if you look on the left, the HLA-B27, it's associated with a lot of things. All right. Why don't we do this? It's 9:45. We'll pick back up at 10. So take a break, stretch, do what you want to do. This is a chart for you. If you want to use it, if you want to fill it out, if that's helpful for you to study, go ahead and do it. We'll come back at 10. We'll do a couple questions and then kind of keep rolling. Non-traumatic, with fevers and chills. Joint is swollen and warm to touch with a limited range of motion. What is the most likely diagnosis? Which one can you rule out first? Rule out D. It's not going to be an acute degenerative problem. Okay. What else can you rule out? What?
E.
E.
She said.
Yeah, there's no such thing as a real acute rheumatoid arthritis. You can have flares, but right? That's not really a thing. Good. All right. So for A, B, and C, can you tell in this patient if it's going to be A or C by her history? No, both can affect the knees. It's a young lady. Oh. She's probably not going to get gout. She's at lower risk for that. Yeah. So I thought the most likely thing, did it flush? Did you? There we go. Infectious arthritis or
quit?
septic arthritis. Yeah.
No.
Oh. Yeah. A 66-year-old male complains of unsteadiness with gait that began several months ago. He's now developed pain in the lower back and upper thighs that's relieved with rest. Peripheral pulses are strong. MRI shows diffuse narrowing of the spinal canal. For symptom reduction, what should he be counseled about?
It didn't switch.
You can switch. Okay. Thanks. Here's your patient. So first of all, what the heck is going on? We didn't talk about anything in the spine yet. He's got gait unsteady. That's like a neuro problem, maybe. What do we think is happening? There are a lot of whispers. Phil, any idea? Spinal stenosis. Look, came right out with a diagnosis. Yeah. Okay. I agree. I think it is spinal stenosis, which we haven't gotten to. So bonus point. But yeah, he's an older guy. Okay, so that's kind of in, you can start thinking osteoarthritis issues, right? Unsteadiness of gait, well, that could be neuro, or it could just be something else, right? Now he's got pain in his lower back, okay, very classic. And upper thigh. Well, he's got back and hip arthritis, which could happen. Or he's got a back thing that's giving a neurologic complaint to the thighs, okay. Better with rest, that's a good hint, arthritis, there's some neurologic, we're still in on that. Pulses are fine. Great, not that the orthopedist would think to check pulses. Someone got an MRI without an X-ray, that insurance would never go for that, it's bad practice, but the MRI shows diffuse narrowing of the canal. Okay, so that can be from a couple things. It could be from basically spine arthritis, those bone spurs. They kind of narrow and enclose the spinal canal, that's giving him the neurologic symptoms. Okay, so we kind of figure that out, even without having any basis for this. But for symptom reduction, what should he be counseled about? For patient education, now that we have a decent idea. Kevin, what do you think?
So my PCE, I worked for a spine doctor and of course weight loss and exercise, but she would absolutely give that steroids.
Okay. So probably a good clinical application. Maybe a little bit of everything. Might we could hold off on surgery.
Yeah.
So yeah, typically you do a couple things at once, like with the osteoarthritis. So you talk to the patient and kind of let them decide, right? So first things, if this said initial thing the patient should be counseled about, I agree. The first thing, and these kind of go in order, right? Weight loss and exercise, first thing to try. Then we get into some of those adjunctive things. Love it. All right. Patient with long-standing, so chronic now, rheumatoid arthritis develops. Did it not switch? Did it switch?
Yeah.
Oh. You know, technology. The patient with long-standing rheumatoid arthritis develops a left septic knee. We already know it's septic. The infection was most likely spread via what route? C, hematogenous spread. Yep. That's because of probably the medications and the treatments, there's higher risk for that. 58-year-old patient complains of pain in the hands that worsens with activity. It reports stiffness of less than 15 minutes during, that's common during or after periods of non-use, particularly in the morning. Just based on that history, what's the most likely diagnosis? What? It's like a general murmur. Or it says B, correct. And all you really need to see is that less than 15 minutes. That's enough to clue you in between osteoarthritis. All right, 62-year-old obese female complains of pain in her left groin. That's been getting worse for the past year. Better in the morning after she showers and worse in the evening after her activities. On exam, there's decreased active range of motion and pain with internal and external rotation. What's the initial recommended treatment for the most likely diagnosis? So what's going on? Does she need a hernia repair? Probably not a rheumatology day. What's going on?
Arthritis over SL.
Arthritis, what kind of arthritis? Nick, what do you think? You want to whisper? You want to say? You whisper. It's probably one of them. I agree. So what hints did I use? What hints would you use in the question?
Better in the morning.
Okay, better, so warmth, a little bit of movement. What else, Jacqueline? Okay. Yep. What else? The stiffness. What else, Chris? Obese. Ooh. Weight bearing, obese. Anything else? Yeah, when it's getting worse. Okay, so we think it's more kind of a chronic or osteoarthritis, right? This seems non-inflammatory. That'd be more down the osteoarthritis route. What's the initial recommended treatment? Gosh, that's so sneaky. I would never give that to you as an exam question. Don't panic. But technically it's acetaminophen. I agree with Kevin. I'd probably give them NSAIDs. I think it's gonna be more effective. That's probably clinically what you do. When you look technically, it'll be acetaminophen. All right, here we have a 56-year-old male who presents with pain in his first toe that awakened him from sleep last night. It was so painful. He couldn't even move or touch his toe. He does drink 4 beers every night after dinner. His toe's red, dusky, swollen, tender. I don't know why we got uric acid, but we have it. It's 8.4. Which of the following would most likely be found on examination of the synovial fluid? What, Jackson? D?
Yeah.
D? Uh-oh. I know. What do we think's going on? Gout. So are we looking for positively or negatively birefringent? Negative, yes. Pseudo gout is positive. The P's go together. Pseudo gout and positive. Yep. So I do think it's D. Most likely, we don't know until I can look at those. But being that it's in the toe, it's more common for gout than pseudo gout. 32-year-old female gives history of chronic aching pain, especially the neck, shoulders, back, hips. She complains of fatigue and frequent headaches. Examination reveals several trigger points of pain on palpation. What's the most appropriate intervention? Does anybody have any ideas about what could be going on? This is nothing we talked about quite yet. 32, chronic aching pain, neck, shoulders, back, and hips. Fatigue, headaches, bless you. Trigger points on palpation. Is there anybody's memory of something? I don't know if you heard about this before at all.
Did I say it?
I don't know.
you say it?
Fibromyalgia. We'll talk about it. We haven't gotten there yet. Let's just see what you might know. Fibromyalgia. Any ideas on what the best, and again, you might do a couple of these things at once, but what would be the first thing you do? Are it gonna be opioids? No, it's hardly ever opioids, so that's good news. What about the other things? What, Lydia? Exercise. It's probably the first thing you tell someone to do. Yeah, so we'll talk about this. But if you like your graphs and charts, here's more graphs and charts, right? Monoarticular, polyarticular, classifications, however you want to look at. All right. Thoughts, questions? Thoughts, questions on any of those conditions? Okay. You want to fill out your chart later, you can help you study, it's totally up to you. Oh, man. Put the wrong one. We got a blackboard at the right. Oh, it's only black. All right. This is only 39 slides, so I'd like to see what we can do here. Let's start with this. Actually, let me see if I can get the right one. See if I can get it. Things that go into it is autoimmune. I'm gonna leave that more up to Professor Newman and some patho things. This is why we have rheumatology. It's complicated, it's really complicated. If you look in the top left, you can see, you know, a bunch of those markers. We're getting better at discovering these markers and trying to correlate them for earlier diagnosis and maybe better control and treatment of some of this pathology. But basically, it's when the body is attacking itself in some way. We talk about ankylosing spondylitis. This is more common in men. This and gout. Those are two that are more common in men, okay? When I talked about the sacroiliitis, the SI joint involvement, remember it was unilateral before with psoriatic arthritis, it's bilateral here. So this is a chronic inflammatory disorder that affects parts of the axial skeleton, right? Everything else we've really been talking about, you know, limbs, extremities, and those kind of joints. This is the axial skeleton, which is pelvis up to neck. You'll notice these patients have pain and progressive stiffness. more common in males, and this starts young, late teens, early 20s is kind of when this onset will happen. So although we're all used to hearing, I'm used to hearing patients complaining about back pain with the patient population that I deal with, this is different. When you have a teenage, young, semi-healthy, active male who's constantly complaining of lower back pain, seems a little off. This is something that could be considered. All right, just like other autoimmune processes, there's a lot of other symptoms that can happen, but typically you're going to hear a gradual onset with that back pain, kind of maybe some buttock or glute discomfort and radiation as well. There'll be back pain that's worse in the morning, and this stiffness lasts for hours. Okay, so not less than or more than 30 minutes. This is hours, half the day, the whole day. Generally, if they do get up and move, they can kind of warm up a little bit. So it does get somewhat better with activity, right? More of the arthritis and some kind of the acute problems we might see with an active child. That usually is worse with activity, better with rest. This is different. This is better with activity. Stiffness improves. The symptoms start in the pelvis, the SI joint, and then move north. They move up towards the head. So that progressive stiffening starts in the SI joint, goes to the lumbar, thoracic, cervical spine. They may also have some other symptoms like esthesiopathy, which is kind of like a bursal or bursitis involvement. And then there's some systemic things that can happen as well. Again, uveitis, cardiac things, pulmonary things. So when you look at this, they will have increased inflammatory markers like Seterate and CRP. They will have that HLA B27, that marker. Can confidently say they'll have a negative rheumatoid factor and anti-CCP. Some of the classic findings, I have the pictures on the next slide, are these bamboo spine. And as that progressive stiffening happens, you can see that change on X-ray. So the first changes that you'll see on X-ray are in the SI joint. That's exactly where the symptoms start. They start low in the pelvis and move up. So this will be a bilateral and symmetric SI joint involvement, different than psoriatic arthritis is kind of unilateral. You'll see things, they say that the vertebrae looks square, there's this dagger spine. You're really concerned, you can get an MRI for some early imaging, but this is kind of what it looks like. It's very unique to see. That dagger spine is around the yellow arrows. The green kind of shows you that bamboo spine. That's kind of why they're describing it that way. And then you see some of the progression there, the fusion of the SI joints. So obviously if they're losing mobility, that stiffness is a physiologic stiffness. It's not because they need to stretch or go to therapy. It's because literally the bones are fusing together. So they cannot bend as much as they would like to. That does put more strain, of course, on the joints below, which are the hips. And as they get up to the top, even around their ribs, and some other mobility of the chest wall. And that's where some of the cardiac and pulmonary complications can really be seen and exacerbated. Now, NSAIDs are the treatment of choice. In ankylosing spondylitis, we think this will have an effect on that sclerosis of the bone, that hardening, that fusion of the bone. So NSAIDs can slow the progression. That's why you need to find this as early as possible. You can use some of those biologics, those tumor necrosis factors, TNFs that we kind of brought up a little bit in rheumatoid arthritis. But generally, we don't give these patients corticosteroids. Probably not going to help their symptoms all that much. And it is going to worsen their risk of osteopenia, osteoporosis. You can imagine they're at higher risk for any fractures in there, can be catastrophic. All right, so they go to PT not to increase their mobility. It's not physiologically possible. They go to PT so they can learn how to function with the mobility that they have. All right, so it's almost to give more occupational side of that. All right, it's to maintain what they have, function how they can, given that this is a progressive disease process. And then because the lower back, the SI joint kind of all get fused and stuck, they can't, bend, twist, turn. They get a lot of secondary hip disease, meaning ball and socket, hip joint, lower down in the pelvis disease, because the hips are doing mobility for the hips and they're being overworked trying to compensate for the fact that the spine will not mobilize. I've seen some of these patients come in for hip replacement. Very unique surgery, a lot of other considerations. So a lot of patient education out there. You can see some people change their diets. They'll have to go through some lifestyle changes. There's a lot of patient education with this, especially because you find this in much younger patients. Kind of mixing and matching and looking at spondyloarthritis, the spine stuff, versus maybe psoriatic arthritis or other peripheral things in the limbs. Like charts, here we go. I'll talk about lupus specifically. We're talking about systemic lupus erythematosus. So there's 5 subtypes of lupus. They're all obviously a little bit different, but we're going to talk about SLE. That's the most common one. This is an inflammatory and autoimmune disorder. So those autoantibodies are reacting against kind of the nuclear components of the cell. So what's in the nucleus? Now the symptoms can be variable, but this is systemic, so it can affect many organ systems, and typically does. Classically, patients will have courses of, flares and seemingly spontaneous remission and relapse. So things are better and worse, and sometimes they can correlate it to stress or what they're eating and sleep, but a lot of times they can't. Very common in women, and there might be this genetic component as well. Now you look on average, commonly diagnosed between age 50 and 44, so that's a wide gap. But again, when you have those younger patients specifically complaining of variable symptoms, you can't figure out what's going on and you end up kind of looking at an autoimmune thing. That's something to consider. This should be treated by a rheumatologist. Most patients with lupus will have a positive ANA. Again, signs and symptoms are going to be variable. They're frequently systemic. The common thing you'll see is a rash, this kind of malar or butterfly rash across the face, photosensitivity. In discoid lupus, you'll see a discoid rash. So the subtype of lupus might depend what you see. But arthritis is often the first symptom. So they may or may not have this synovitis, which is more of that rheumatoid arthritis picture, right? Those boggy things. They may or may not have some swan neck deformities in the hands. They'll probably have some eye symptoms, whether it's, photosensitivity or dry eyes or some vasculopathy. Might have some oral ulcers that come up, and those can be painless. Could be neurologic, hematologic, renal, pulmonary, and cardiac complications as well. Because this is systemic, it's in the nuclear part of the cell. This can have a lot of very significant systemic problems. All right, so we try to find this. ANA is positive in almost 100% of patients with SLE. So that's when we feel pretty good about it. That's kind of the screening, the broad test. So hopefully if they have a negative ANA, we can rule out SLE. But we know ANA is sensitive, it's not specific. It's also typically positive in a lot of other autoimmune diseases, as well as, quote, 20% of healthy adults, or maybe that's 20% of people who just haven't been diagnosed with something yet. All right, and this one, SED rate and CRP, or what we kind of draw to look at symptom severity over time. And look at different autoantibodies as tracking. You need to keep an eye out on those CBCs. The cytopenias can happen because the hematologic system is greatly affected. So for ANA, you see there, you can draw titers and maybe that's some of the criteria. But here's some general criteria. So this is more of a clinical diagnosis. There's not one specific thing that can objectively say yes or no. So this is, again, pieces of a puzzle we're putting together. American College of Rheumatology says if you have 4 or more of these criteria, you can be diagnosed with SLE. So the mnemonic is SOAP Brain MD, and you can see all those things there as the mnemonic for the diagnostic criteria. My aunt has lupus. She's been in chronic prednisone and every medication under the sun for the past 50 years. She was diagnosed young. She has very severe osteoporosis, fractures, complications, cardiac and vascular disease, all secondary from lupus. My best friend from P school's mother has very severe chronic systemic disease as a side effect of lupus. So when you see this kind of happening to friends and family around, it's very impactful. So watch what they can struggle with. As far as treatments, you want to target the symptoms. Consider the severity of the symptoms, risks and benefits of what you're doing for treatment. Hydroxychloroquine, that got some big news when COVID came up, right? Maybe we were treating COVID with that for a while. Maybe that would help. But that'll treat the rash and some joint symptoms. May help reduce flares, maybe not, but it's commonly used so that you can associate with lupus treatment. Corticosteroids can be used as well, either acutely for flares or chronically. My aunt has been on a low dose of steroid for almost 50 years. She can't seem to get out of it. There's immunosuppressives, and a lot of this too, you want to add some patient education. So you see kind of that classic rash there. Remember that rashes look different on different skin tones. So it might look different, you might not be sure, but on different skin tones, it can present and look a little bit differently. But these patients need to be educated about the photophobia, right? Wearing sunglasses, even on a cloudy day where the sun can be reflecting, wearing sunscreen all the time. Using topical steroids for rashes can be okay, but they need to be very aware, staying up to date with their screenings and any immunizations. So, you hear, oh, these patients, get this shot when you turn this old, or if you have an autoimmune thing, and this is one of those where patients might get immunization kind of earlier than the stated age. So there was a little bit of, I guess, press about this when, you guys know who that is?
Selena.
Salina. Yeah, so Selena has SLE and she had a kidney transplant. And, it was great in the news, one of her friends gave her a kidney and all that. You kind of see that picture on the left. And then I think much later, she really came out and said, look, here's some of the realistic things that I deal with that the press doesn't highlight in a positive way, right? My moon phase, my weight gain from the steroids, that I'm shaking with my hand, all those secondary things. So kind of on the left is what the media more portrays in a positive light. And then she kind of spoke out about her truth and what it's really like, some of the difficulties and how in the pressure can be educated. So we have another dose of reality. Jalen, do you want to share anything about your experience?
Yeah, so at the top, right, that is when I first started experiencing symptoms. And so I put it next to the other pictures that you guys can compare, like, I got really, really sick. I lost a lot of weight. I explained it as like, feeling like my arm was literally just gonna like fall off. Like, it just felt like my body wasn't my body. It was very weird to explain. It's just, everything is just inflamed. And then at the bottom, you can see how on the right, that was my mood face from the prednisone. I started off, like Professor G was saying, like, there's just so many different symptoms. And so for me, I actually played basketball in high school and I had to end up stopping because of my lupus. And that's actually how I figured out something was wrong. Just randomly, like my sophomore year, I like couldn't do laps anymore. Like, I was getting really out of breath. I was having like this really, really bad shoulder pain. And at that time, of course, I'm like, 14, like 14, and so they just kept saying like, oh, you like hyperextended your elbow, your shoulder, like shooting or something, like, they're like, oh, it's just a swimmer shoulder. And then that like would finally go away, then I sprained my ankle, then got over that, literally the game I came back, sprained my ankle again, and I was just like, this isn't me, like, I'm really, really weak, like, something is wrong. And then, I started experiencing really bad chest pain. And so that's because for me specifically, my flare symptom is pericarditis. At that time, of course, I didn't know what that. But, I just had like really, really bad chest pain, like many, many nights up late, crying, just in pain. I couldn't, everything learned pretty much, like I couldn't lay back, flat at all, like it would hurt so bad, I felt like I couldn't breathe. And, as Professor G was stating, like, it takes a long time to get diagnosed, and so like, that's a hard part of it too, because it's like you're going through all this, and they can't tell you what is going on. I think mine was actually on the quicker end. I think from symptom to diagnosis, it was a year for me. And even still, it started off with them just diagnosing me with the pericarditis first, and then, I was seeing a cardiologist, and then he actually was the one that was like, I think this is more. So then I started seeing my uncle rheumatologist. He's been with me the whole step of the way. Trying to think. Oh, in that wound phase, just to kind of put it into perspective, I was actually on like, I wasn't even on a high dose of prednisone. I was only on like prednisone 20 milligrams, and I still, got that weight gain. I was on it like every day. And I think I was on it for a few months. And then it started tapering me down. But to really put it in perspective, I was on prednisone in total for like 2 years, I think from 2015 to 2017. And thankfully, I have not had to be on it since like 2021. Trying to think what else.
I mean, how'd you feel as a patient for a whole year getting poked and prodded and ignored, maybe you're
Yeah.
brushed off?
It's a lot, and then especially because like even just explaining it to you all, like it's so hard to explain how you're feeling. Like you're just like, I know my body, I know like this is not me. Like I just feel weak. And then as you can imagine, like I'm like 14, 15 going through all this. So then of course like my mom is like, my mom is not a medical person at all. Like one little thing happens and she's like, oh. So she, like my mom, just going through all of that at a young age, it was very hard. And then just being like young and, in high school through that, and you don't want to deal with like people and nobody knowing what it is, and then people trying to call you sick and all of that. So it's like, it's a very challenging thing, not just physically, but mentally too. And like Professor G was just, saying, it's a lot. Like, I don't even know how to explain it. It's a lot of testing you're going through. And they actually call lupus like a mimicking disease because it has so many various symptoms that like, they're literally trying to give you everything under this umbrella. And then you're just kind of like, they just keep rolling stuff out, but not ruling anything in. So it just takes a long time. But everything she said was true. Like my ANA was positive, my C-reactive protein was positive. To put it in perspective, like for your set rate and everything, like when you're having inflammation, it all that goes up. Like so at this time, when I first got my diagnosis and I was very inflamed, my set rate was like 95. Your normal set rate is supposed to be like 30. So you can imagine like your body being that high and being that inflamed all the time, like you feel like, excuse my language, you feel like shit. You just feel really, really bad. And even now, thankfully I'm doing very well. I've went through PA school so far with no flares. We're gonna keep going on with that. But I haven't flared in a while. And like, even when I do have a flare, it's like thankfully everyone around me, my family, and everyone knows how to deal with it now, but it's like, you literally, it's not even just that you don't want to get out of bed, it's like you literally cannot get out of bed.
And how is having surgery as a lupus patient with an autoimmune stamp on your chart?
Yeah, so having surgery, first of all, you have to do a whole bunch more stuff like pre-surgery, like a lot more testing. And actually, so before PA school even started for us, I had my ACL surgery. And at this time, they didn't even know, I didn't find out till after surgery that I have, a positive cardiolipin antibody, so it actually caused me to clot. And that's something that is correlated with lupus, but they didn't know because at that time I never had any type of surgery. And so now, for future like surgeries, even for pregnancy for me, I'm gonna have to like proactively go on a blood thinner because like I clot very easily basically. I got my surgery and they were like actually kind of amazed. Well, not amazed, I feel like amazed is something that's a good thing, but like they were kind of amazed at how quick I got my clot. Like I don't even think it was a week after surgery that I developed the DVT.
Yeah, so kind of having the stamp, there's that first picture in the beginning, with all those overlapping things, there's a lot, the diagnosis of lupus, it might be, oh, pericarditis, and they kind of look retrospectively and be like, it's weird for this healthy 15-year-old to have pericarditis. And then you kind of work your way backwards, you kind of ruling things in or out. You're at higher risk for some of those other things, and they might show up not proactively, but reactively. You find out some of these things kind of the hard way. What else? You're high risk for surgery, you're high risk for having a flare after surgery. Do you need steroids that put you at risk for infection and delays your healing? And so there's really a lot that goes on. And to be diagnosed young as you were, thank you for sharing, middle of high school, everyone's got hormones, everyone just wants to be normal and keep your head down and fit in. And so to have this going on in the midst of it, whether it's lupus or another diagnosis for, young people of that age, you've always got the psych differentials. Oh, they just want attention, or oh, they're making this up. And some of these things are very subjective, right? You can't rate your fatigue. You can't tell me what it feels like. There's some objective things that once you can latch onto, like the pericarditis, that I think gets the ball rolling for diagnosis. But a lot of patients have this general experience and similar threads of their story being diagnosed with an autoimmune disease for exactly these reasons. So again, if you really listen to your patients, that's really the key. Put a lot of stock into your patient connection and your history. That's really going to help them get to a diagnosis faster. And
I can say that it does make you get like very, very in tune with your body. So like the slightest thing can happen. So like mine is I start getting like this like little like pins and needles feeling in my fingertips. And I'm like, oh, a flare is trying to come. And so like I'll start, I'm also like kind of just into trying to figure out more natural ways. So like when I start feeling that, I'll start going crazy eating like spinach, like the dark leafy greens, and I have like turmeric supplements that I take. All that is just really good for like anti-inflammatory. So you just get like really in tune. And I know like Aisha always asks me all the time, she's like, how are you getting through PA school? You just don't look stressed. And it's kind of like Professor G was just saying, like, you learn your body and you learn what makes you flare. And so like stress, it's like, yeah, PA school is stressful, but for me, it's like, it's bigger than PA school. Like that could literally be me being in a hospital bed and me being here. So it's just like a matter of just learning how to navigate it and knowing my body.
yeah, thanks for sharing. I mean, this is where even in patient education, there's resources. Some people cope well mentally, some don't. Some people support their bodies, some people choose to listen, some don't. So you'll see, different patients that are just angry. They've been through this, people are treating them like they're crazy, right? And so then they get angry, and there's a whole scope of reactions that you'll see from patients kind of through any process of any diagnosis, but specifically in the autoimmune space. There's really a lot to think about as a provider because we can't all emulate and have that experience, but trying to be aware, my aunt is into a lot of holistic things and I think that supported her pretty well. My best friend's mom was told never to get pregnant because it would definitely kill her, literally in very, very harsh words. So they call my best friend literally like a miracle baby, and she was born at 20-something weeks because of complications with lupus. And so, there's a lot to consider in terms of not just the diagnosis, but, long-term future and planning and what that could mean. So thanks for sharing. Appreciate it. All right. Oh, I'm trying to use the thing. All right. We're going to keep moving on. I have about 20 more slides for the day. So good to keep going. Okay. All right. So I'm talking about scleroderma. This is progressive systemic sclerosis. So this is basically fibrosis of skin and internal organs. So visually, what we usually think of and see, skin. What we can't see is also having the same process. So again, it's more common in women. There's kind of two types. We'll focus on the crest type because that's much more popular. That's the quote limited type, but it's about 80%. That's also the diffuse type. So I have crest on another slide, but generally speaking, crest is going to be, symptoms in the face, neck, skin, distal to the elbows, distal to the knees. Going to see digital ischemia and some pulmonary hypertension very commonly, but then the diffuse version, you'll also get the trunk and the other parts of the extremities, plus some cardiac disease. So, not to muddy the waters too much, but there's a strong association between Raynaud phenomenon and scleroderma. We'll talk about Raynaud in a second, but link those two in your mind. Raynaud is commonly associated with scleroderma. In fact, it's the first initial manifestation for most patients. All right, so there's kind of this cutaneous disease. You'll see non-pitting subcutaneous edema. So remember in your physical exam lab, I was looking for pitting edema, heart disease, heart failure, checking the extremities. This will be non-pitting edema. So you'll see it kind of a thickened, or people say like a hide-like skin. You'll see in the bottom picture, the top picture very classically, sclerodactyly. It's the tightening of the skin in and around the fingers, and you'll lose the normal skin folds. Of course, with that, you lose more mobility. So you get some of the same frustrations as those rheumatoid patients. You can see telangiectasias, which are like, kind of spider veins, small vessels there, pigmentation changes, ulcerations, even on the fingertips, and then systemic disease. These things are hard to see, right? Patients come in, we can't see. Sometimes you'll get labs and testing, but you want to listen for those things in a history. Someone with dysphagia, GERD, pulmonary fibrosis, restrictive lung diseases, these can all be found first and then linked back to this. All right, so when we talk about scleroderma, the ANA is usually positive. That's kind of our broad screening test for autoimmune disease. They may or may not have this scleroderma antibody. So again, it exists. Can they have scleroderma without the antibody? They can. This is what makes rheumatology in labs a little hairy. For treatment, you just want to focus on the involved organ systems. So skin, that's the first thing to usually see, right? But there's probably something externally. You find scleroderma. There's things going on internally. You need to look for that. GI, pulmonary system, cardiac system, right? You can't kind of put scleroderma as a full disease into remission, if you will, but it's managed by rheumatology and it is a systemic treatment. So you might go into some of those biologics and those other systemic treatments. When we look at CREST syndrome, this is the 80% of scleroderma. So CREST syndrome is a kind of subset of scleroderma. This equals scleroderma, right? But CREST is a mnemonic for calcinosis, Raynaud's, esophageal dysfunction, sclerodactyly, and telangiectasia. So that is what you'll see in those kind of limited disease variant patients. You'll see some of those calcium deposits in the skin. Those also kind of look like gouty tophi. So you want to listen for Raynaud, which we're going to talk about next. Esophageal dysfunction, that's going to be severe reflux or decreased mobility of the esophagus, right? The sclerodactyly and telangiectasia we kind of talked about. So for Raynaud, this is considered a benign condition. All right, so this is associated with scleroderma, but Raynaud by itself is benign. It's not thought to truly cause vascular damage. We're talking about all these things that are autoimmune or whatever, then we have Raynaud. Okay, so by itself, it's considered benign. They think it's paroxysmal digital ischemia. Maybe the vessels are spasming and affecting the perfusion there on the fingertips. Usually it's associated historically with cold outside, stress. Again, it's most common in women. There's kind of these two phases. There's excessive vasoconstriction, which you get, white and blue, cyanosis and pallor. And then you get excessive vasodilation. So you'll see a lot of red. Right, for that reason, we call it the red, white, and blue disease. Some people have this and they don't have any pain associated with their fingers looking like that. Some people hate it. They say it's painful and they get numbness and tingling in their fingers when this happens. Classically, it's the fingers. I will say, some of you know, one of my best friends, her mom lives local. So I'm here several days in a row. I usually stay with her. She has Raynaud. She does get symptoms in her fingers. She grew up in this area. She has Ravens season tickets. It's interesting to go to a Ravens game with her in the cold weather. I'm not a cold weather person. I will go if the Steelers are in town with them. Every, her fingers, I know her toes will do it too. The most interesting thing, and I need to take a photo of this, is her tongue gets just like the colors of those fingers. Her tongue will blanch and turn completely white at the end. Sounds crazy? I should get a picture. But that is, mostly it's the fingers, but in her, it also manifests in the end of her tongue, her ring. So what she does is exactly here, patient education, hand warmers, gloves. She's got all the thermal things. You plug in the battery, heated packs. I mean, she tries to do it all. She's drinking hot liquids and soups and all that. She's not going to take a cold beer on a day like that. So she'll make like a hot toddy thing, but that's it. If it's really severe, bothersome, painful to patients, you can put them on a calcium channel blocker. But really it's benign in the fact that it's not damaging the vasculature and we don't think it's going to cause any kind of long-term things unless it is a part of Crest syndrome, and scleroderma is the underlying reason why this is happening. So there is that association, that's why I included here. Yeah. You like to classify things or charts? Sjogren's syndrome. This is another thing that my aunt has. So once you have lupus or one autoimmune, you saw that graph, there's a lot of overlap. Kind of like her daughter, ironically, is a type 1 diabetic with Graves' disease and celiac disease. And I'm forgetting one. PCOS, and there's many. I can't count on one hand, so I know I'm forgetting some. But, once that autoimmune thing happens, you have to be very aware and listen closely and look for other things. So Sjogren's is one that is, again, highly associated with other autoimmune diagnoses. So this is systemic, it's autoimmune, and it's mostly a dysfunction of the lacrimal and salivary glands. So that's kind of what we think about classically. Dry eyes, dry mouth. And it's not like, oh, I just need to stay a little more hydrated. Those glands aren't working properly. All right, so it's, again, common in women. You'll see it typically in RA patients. You'll see it in lupus patients like my aunt. The common signs, ocular signs, we call this keratoconjunctivitis sicca. That means dry eyes, right? And it's not because, it's windy outside or it's allergy season. It's because there's not enough tear production. That's why they have dry eyes. So they might tell you, oh, it's burning and itching. It feels like there's sand. You say, well, it's allergy season. You call it allergies. Well, this is a different reason for having those symptoms, right? For the mouth xerostomia, that's dry mouth. They'll complain with cotton mouth. They may not eat certain foods, crackers. Oh, I can't, my mouth is so dry, I can't eat crackers. Or, they'll only eat certain foods. They won't want to eat a hamburger because the bun is so dry. So they'll be sometimes selective about their foods, and that's how that impacts them. And then, systemically, they can have vasculitis. We'll talk about that in 2 weeks. Pleuritis, airway disease, lung disease, and then dysphagia as well. So dry eye, dry mouth, most common things that you'll see in here with this, but it is a systemic thing. When you do labs for this, you might see, again, some mild anemia, that's more chronic disease stuff. They'll probably have a positive rheumatoid factor. So go figure, you'll find a positive rheumatoid factor, maybe more commonly in a Sjogren patient than a rheumatoid arthritis patient, although they are linked, so maybe they have both. They'll have a positive ANA, that kind of broad spectrum screening. And then if you want to be really mean, you can order this or send them to someone to order this Schirmer test, which is nicknamed the Screamer test. The picture on the right, they take this little strip of paper, they kind of tuck it in the bottom of the eyelid, and then they leave it there for 5 minutes. And it basically is measuring the quantity of tears secreted. So if you look at the picture, little, minimal, kind of normal amounts is at the bottom. You can tell that even though the eye is irritated and needs to produce tears, it can't. So it's lack of production. And that's a super, super miserable test to put anyone through. So I would not recommend it, but you'll see it. Now you know what it's for. Treat this, keep something nearby, try to, affect the dry mouth as much as possible, the artificial tears, sugar-free gum, avoid decongestants, allergy medicine that's going to dry you out even more. There is medication and stuff for this, but that's really going to depend on the severity of their symptoms. All right, we talked about some immune-mediated inflammatory myopathy. So myopathy, now we're talking about muscle conditions here. All right. Immune-mediated myopathies, these are characterized by progressive muscle weakness. And we're talking about striated muscle. Cardiac, skeletal, striated. Talking about striated muscle here. We don't know why this happens. Of course, it's still more common in women. And this can overlap with other things like lupus, like Sjogren, which also overlaps with rheumatoid. So the most common two we're going to narrow down, because there are many, are going to be polymyositis and dermatomyositis. There's a bunch more, and we're going to gloss over those. So polymyositis, many, myomuscle, itis, inflammation. Many muscles are kind of inflamed, affected. So it's progressive muscle weakness. And where polymyositis affects is those red areas. So it's the proximal muscle groups of the upper and lower extremities. So everything that's red, plus the neck. It's a very unique distribution that's affected. So typically, you're going to get the bigger muscles, like the leg muscles affected first, then the arm muscles. So the first chief complaint you're going to hear is, I can't get up out of my chair. Well, it's hard to get up. Which is such a non-specific chief complaint. This is not the first thing you will, or maybe even should think of, but another thing they'll tell you is dysphagia, and that's the striated muscle that's affected. So remember in your esophagus, you have some striated, some skeletal muscle, smooth muscle. So for this is kind of a little bit what they should be able to control, but they can't. So they can't kind of force swallow something. So they'll feel, let's say you feel like I'm going to choke on my food, or they're afraid to eat solids, they have small bites, things like that. So lupus affects smooth muscle, which causes a totally different type of dysphagia. But this affects striated muscle. All right, for dermatomyositis, this is more of the skin components that you're seeing. So dermatomyositis, you're going to find a characteristic rash. They also call this a malar rash. When we just talked about lupus having that butterfly malar rash, photosensitivity, this is different in that they're going to also have facial erythema. Probably some other stuff, periorbital edema and heliotrope rash, so that purple eyelid. It might look like they're wearing beautiful purple eyeshadow, and they're not. All right, they'll have something called a shawl sign, where you're going to get erythema over the face, neck, shoulders, upper chest, and back. Anywhere where you kind of lie a shawl. It would look like something irritated in the shawl. They were wearing it, and that's the area that's affected. You can get this Gottrin sign, so red rash on the extensor surfaces, fingers, elbows, knees. That sounds like psoriasis, right? Extensor surfaces. So you can see how some of these easily are hard to figure out. You can have these Gottram papules, these lesions, you know, kind of in and around the fingers. Not to be confused with maybe a gonococcal dissemination or a rash there of reactive arthritis that can look similar. And then they can have scalp involvement. Again, that can easily mimic psoriasis. We compare and contrast these two. You know, polymyositis, really, you have to diagnose that with a muscle biopsy. The thing is, these inflammatory myopathies are typically treated with high-dose steroids. Got that autoimmune component, trying to turn that off. So for workup, again, you typically want to get a biopsy to see what you're dealing with. Typically, treatment's going to be high-dose steroids. If you look at the differences in the biopsies, it really depends if it's perifascicular, perivascular, or if it's the fascicle itself. So you're looking at what part of the muscle is being affected. That's a biopsy to differentiate and confirm what's going on. You get muscle enzymes, like if you think about compartment syndrome, you're going to get a CK, plus or minus an ANA, so that's not super helpful. Some people going up, undergoing workup, especially for the polymyositis, you know, all those neurologic things that can mimic that. They might undergo EMGs. So to confirm that it's this, you need to get that biopsy. Treated with high dose corticosteroids, that's the mainstay of treatment. High dose daily to start. Usually you can taper down, but probably going to be on these maybe for life at a small dose. If you want to track something else, you can correlate the disease symptoms, not only with something like Settering CRP, but also with those serum muscle enzymes. The more breakdown you have, the worse the symptoms are, the higher those numbers are going to be. You can sometimes treat these patients with methotrexate. That DMARD, that first-line RA treatment, can be used for this as well. All right, same slide, we talked about ANA. Again, I will acknowledge that you can use this for more than we are. Some of these, you know, the Hep2 cell B line, you can look and maybe try to figure out from there what you're dealing with, but take-homes are here. Last question?